All right, can all speakers join us? Now, to be honest, we said lunch at 12:05 and it's 12:05, but we did schedule an hour and 10 minutes for lunch. So let's eat into a little of our lunchtime and see how many questions you can come up with. Step up to the mic if you'd like to be recorded. Let's see. Our esteemed colleague, Dr. John Farquhar, is going to lead off. Are you live, Dr. Farquhar?
Just a quick question for Randy. How did you measure or prevent cross-contamination within your community with, 3 different programs going and they're all in a big neighborhood? Was there a problem of one group infecting the other with a better way of doing things?
So first of all, it's impossible to prevent cross-contamination altogether, and that contamination might occur in several different ways, particularly because we had the same primary care physician might have particular patients in each of the 3 arms. In addition, these are people who live in the same neighborhood, so they may see each other. And of course, those participating in the group sessions, a group session may include those that receive only the case management component, as well as those that are receiving the case management and the home visits. So some of that was unavoidable. We think that some of it is at such a low level that we don't particularly think that it's going to affect the results. Certainly it would have a conservative bias in reducing the magnitude of the size of effects. But particularly for the physicians, those physicians haven't been successful at facilitating weight loss, and to somehow shift to a more effective model where some of their patients are affecting their behavior towards the usual care patients, I think would be unusual. So it is an issue. We're not particularly worried about it affecting the final results.
Dr. Abby King.
So unlike Jack, I don't have to bend down over the microphone. First, thanks for a great set of talks. Each one was terrific. My question's for Bar. Hi. I'm interested in terms of the current and future pressures on schools. Here we're seeing they're getting, physical education is being legislated out of schools and everything. How do you see your curriculum fitting into the school day? And how do you see that working given the continued academic pressures on schools these days?
Yeah, it's a great question, and as you know, Abby, it's a huge problem. The way we have been doing it is to actually have it in health education classes, and we've looked at the state guidelines for health education and said we'll take on teaching these guidelines about nutrition and so forth, and then put it in the physical activity class, but it has to be done on the computer, which, and that's actually worked pretty well so far. So it's the schools really are quite happy to have us take over that function, but it's been both aspects of it. It's both providing something for healthy weight regulation, but doing it in the context of health education.
Did I understand you correctly saying that you're decreasing physical activity during the PE class because the kids are sitting in front of the computer?
You did understand me correctly, yes. One of the ironies. Well, we actually looked at the numbers because it takes about an hour, or 12 hours they lose 12 hours of physical activity by doing this particular program. And, we were worried about that because, you've seen the importance of having these kids not sedentary. But of course, in the program, the whole point of it is to increase physical activity, or at least half of it. So we monitor that, and we try to really move kids outside of the school into doing more physical activity. I didn't show you the data, but we do have some preliminary data because we really, based on Tom's work and yours and a lot of other people, really noted the importance of reducing television time and computer time and so forth. So that has been a major emphasis, and it's a substantially difficult thing to do, but we have some evidence that we succeeded in some of the schools. So we try to balance that with a gain of more time outside of school.
Thanks. Dr. Marcia Stefanik.
So I want to echo Abby's congratulations to all of you. Those were great talks. My question is for Jerry. And it's too bad I couldn't ask you right after your talk because there was a particular slide you showed that were your own data where you had the tertiles of the SSPG and you were showing the total cholesterol and the LDL and the other things. And what struck me was that actually the lines were very parallel, so that increasing weight was really equally bad for all groups. It was where they started, their baseline, that was the most important issue, which from a clinician's perspective I think is fine because it's at baseline that you're looking at that. But my question to you is, you've done a wonderful job of making everybody recognize that being overweight is not equal for all people. But on the other end, so the people who are normal weight, who are already showing those major problems, it seems to me that people aren't even thinking about the fact that they could actually continue on those beautiful parallel curves of yours and improve if they lost weight. And so I'm kind of wondering, do we have the 25, is that set too high for at least certain populations?
It's a complex question, and I won't even try to deal with that last part about what is right for what population. On the other hand, as I tried to say earlier, that differences in weight count for about 25% of that variability in insulin action. And so it's very possible that the people who at normal weight still have problems, not only in our data, but it was more impressive in Wildman's data, where a quarter of those three populations pretty much at normal weight already were unhealthy, quote unquote. Then I think you're talking about differences in genetic makeup, differences in level of activity, none of which are controlled for. So I'm not so sure how much benefit would occur in the insulin-resistant person at normal weight by losing more weight. It's a good question. I'm not sure I'll ever get it by an IRB, but it's really a good point to make. I'm not sure it follows that they would, but who knows?
Go ahead, Jennifer Robinson.
Hi. This question is actually for almost all of you. Several of you mentioned measuring waist circumference in various studies. And I'm just curious to know if you all measured the waist circumference in the same location. I know that there's some different information about different places to measure. And then also just your thoughts on waist circumference versus waist to hip ratio.
Who wants it?
Well, I'm the most skeptical. I think it's a waste of, first of all, I think we measure the same way like the NIH tells you to measure it. I think the very interesting thing in that slide I showed you from the emerging risk factors, blah, 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 what they found that whether you measure waist circumference or waist-hip ratio or BMI, none of them were independent predictors of heart disease, for example. And what they also showed, which I did not necessarily get into, was that looking at the different centers, some of them had actually had done successive measurements, that the least reproducible was waist-hip ratio, the most reproducible was BMI. But certainly in our data, we measure it the same way. And I don't know what anybody else does is their own business.
Dr. Kiernan, didn't you publish a paper called Measuring Waste is a Waste?
Yes. So that was looking at the national guidelines where they had, for the NHLBI weight guidelines, where they had set up this very elaborate and what looked very official algorithm to measure both BMI and waist circumference and risk factors, and it was this enormous 25-step thing. And we went and looked at I'm forgetting the data
Additional predictive value? Or?
Exactly, and we looked at it in a large national data set and basically added nothing to actual BMI, in part because their cutoff was driven from a study that had been coming from BMI. So it was sort of this gigantic circular kind of thing. In our particular study, we started to measure it and was in the grant, and we had just a horrendous time trying to get reliable measures. And I made a really calculated decision that our study wasn't going to add anything to the physiology around waist circumference, and I dropped the measure on purpose, given we were trying to get the women sort of in and out of the clinic visits at that point. And I spent a fair amount of time with a lot of different investigators trying to get a really good protocol, and was stunned at how poor they were. So we worked hard to try and do it and didn't. So
Just a quick added anecdote. One of the hardest things difficult things I had to do or tried to do with our various studies was to insist that we measure waist circumference, because so many of my colleagues felt that it was such a stupid, non-reproducible thing to do that they didn't want to do it anymore. But I knew we would have a trouble getting published if we didn't have waist circumference measurements. That's anecdotal, not scientific. But it's sort of,
I've had a somewhat interesting insight from the clinical viewpoint, which is that in a busy clinic where assistants are weighing people, it's extremely unreliable. People get weighed with or without their shoes, with clothing of various types. And so, although there's a lot of focus on how unreliable waist circumference is, in clinical use, I think the two may not be so different, just because we have failed to standardize weight measurement in a busy clinic. I think there's also a potential, and again, this is a bit anecdotal, that some patients who are extremely frustrated that they have been behaviorally adherent to physical activity and dietary restriction often don't see early success with weight, but frequently do with small changes in waist circumference. So I think that the waist circumference, we shouldn't give up hope on it, but this whole issue of measurement and difficulty training people to do it properly is a huge issue.
I would just caution that, just to say, however, when you bring, so I agree with you on all that. People hate getting it done. And it's just an incredibly invasive thing to have done and incredibly difficult for people who are really overweight. It's very hard to do. You put it inside or outside the rolls and stuff. So it becomes a very psychologically difficult thing to navigate. So I think you have to go in maybe with a subset of patients or a very, very good reason why to do it, given that added aspect.
well, at the risk of being so iconoclastic, why do you care? I mean, I just got through pointing out the emerging risk factor group showed that these measures were not independent, no matter which one you did. There was an earlier paper using NHANES data that showed the same thing, that if they took all the so-called risk factors from the quote-unquote metabolic syndrome, that the only one that had nothing to do with predicting anything was the measurements of adiposity. What predicted stuff were the metabolic outcomes, not the measures of adiposity. So why get so hung up on which one you're going to do? You must weigh them. Oh, never mind.
Because I think it's important because we presume that weight gain is going to cause those other risk factors that are being measured. We don't presume that people with hypertension gain weight because they're hypertensive.
No, but never mind.
Jack?
Yeah, I'd like to try and put together a marriage of the two issues of what you're doing, Randy, and what you're doing, Bar, because you could look at contamination in another way. Bar, if you had all the schools in an area, in a community or a region, or and Randy, if you had all of the adults under some kind of program, the cross-contamination would start to get toward a total community approach, which is, as you all know, what I think is where we need eventually to go. So I just wanted to congratulate both Randy and Bar for that possibility of showing us what might happen if this became more universal. And then within that context, every one of the things that Thomas said and Michaela, et cetera, that if you have all of the good projects going within the context of a universality, then I think we're really getting somewhere. So this was a marvelous set of presentations. And yours too, Jerry.
All right, I got Abby, go ahead. You look tentative.
Well, I want to ask a question to Mary. In terms of the ActiPal, what are the data for the population-wide use of that? Because that seems like something that could solve many of the problems we're facing with Actigraph, especially in terms of 24-hour measurement, and maybe your mights at some point, which I think would be the true solution, will come to the fore, but I know that that's going to be a while. So can you speak a little bit? And I know Marcia is thinking about this question too from our WHI grant perspective. Here we have, 45,000 women or something trying to figure out how to measure physical activity and sedentary behavior. Can you speak a little bit about the possibilities of doing that?
The ActivePal, I think, is a really interesting device. There's a couple of issues with it. The first one is that you're sticking it to the thigh, which is just a little more uncomfortable than wearing an actigraph around the hip, and so the rates of adherence might go down a little bit with it. As far as accelerometers go, they're all sort of measuring the same thing now as far as physical activity and the different levels and that sort of thing. And so I think it can be really, really useful. But there isn't as much research on its validity and that sort of thing. So that's the two issues is people might not want to wear it, and there's not as much validity out there on it. I think it's really promising, though.
Okay, I'm going to take advantage of the podium here and maybe ask the last question before we head off to lunch. I'm going to ask a loaded question maybe of each and every one of you, maybe Tom to start because you didn't get to answer yet, but this could be just a one-word answer. So in everything I heard just now for the last hour or so, we found different ways of identifying, targeting subsets of the population that might respond better or be at greater risk. And we have innovative new interventions that don't always work for everyone, but they might be innovative and work in a new way for a subset. So just in terms of your work as interventionists and health professionals, are you more excited or discouraged that with these methods we have, these scientific methods, are we being shackled to interventions that get diluted and then we have to report small effects? Or are you excited that our tool chest is getting more and more filled with targeting social movements or identifying sedentary behavior or finding the stability first folks? Is this a really upbeat time, or or do we have to shift our whole scientific paradigm? Simple question. Excited or discouraged? Tom?
I'm very excited. And it's also in measuring outcomes. I think we're identifying a lot of new potential outcomes other than just weight. And you can pass if you want, Jerry. We'll just go down the line here. He's excited. He's passing. Mary.
Yeah, I mean, I'm really excited. The more I learn about this and the more complicated it becomes, the more exciting it is, right?
So you're not stressed that your effect might be diluted. There's some sedentary folks and some really active folks, and measuring this, it's going to be good all around.
Yeah, we need both, right?
Bar's going to tailor his
I'm very
online
excited. I
intervention.
think it's really
You look great.
wonderful time.
I'm excited as well. I think there are a lot of challenges in terms of trying to identify and tailor to specific populations. We don't always have the clinical trial infrastructure to be able to do the larger trials that are going to be necessary. But hopefully all this excitement about technology will require the larger studies and the more definitive studies that can take advantage of the technology.
Go ahead and close.
And I just say, as a field, I think we've done a terrible job at tailoring things to date, and it's really wide open against the one-size-fits-all. I think we have tons of things that we can do now.
Because I guess that's what I'm having the most fun with. There's not just the low-fat and the low-carb diet, just from the diet perspective. And all I've heard this morning was just some really great insights into targeting and improving assessment methodology. So we have a fabulous group of folks at Stanford. I hope we'll collaborate with folks in the audience. And now we're going to have a great lunch and a full hour for a break, and we'll come back for a third session. Thanks to all the panelists.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.